Thank you very much. Let's see. Yes. These are my disclosures, not relevant to the presentation of today. So I want to come back to the first presentation of the session. I like this review very much by Professor Kuhlmann because it states that progression in general, also cognitive progression in MS, is driven by an overlap of different mechanisms. And we've heard about this already in the pathology lecture, in the MRI lecture, but I will go back and forth between the clinical side and the MRI side of cognitive decline in MS, and you will see there are many different mechanisms which makes it quite difficult to capture this in clinical practice. But we're doing a lot of work and research to hopefully incorporate all of this, a balance between damage, repair, and compensation. So to begin, I wanted to mention how we actually measure cognitive impairment, cognitive function, cognitive decline in MS. There are three main approaches, at least in research, that we use nowadays. On the left, you will see the brief repeatable battery of neuropsychological tests, which has been extensively used in research and validated for MS, which is a battery of many different domains, but the domains on the left, the DSM-based domains, you will see that spatial processing and executive functioning are lacking as well. So this is also a reason why this domain is very good, but perhaps not enough. If you move to the second one, the MACFIMS, this is the sort of gold standard that we have now. It captures all the relevant domains in the DSM, so not just the MS relevant domains, but all domains. But as you can of course, think, it is very long. So this is quite a long, extensive battery to use. So it's great for research. And if you do a lot of research, but you don't have enough time, but you still want to do more, you can do the BRBN. In clinic, if you really don't have enough time, then there's the BICAMS. The BICAMS is a I have a picture here, yes. The BICAMS is a shortened MACFIMS battery that captures the domains most affected by MS. So as a sort of initial grasp of what's going on, this is great. And if something comes out, perhaps refer your patient for more extensive neuropsychological assessment. These different tests that are used in different batteries have to be validated for MS. That means we have to know that they capture something relevant in MS patients, and also that it has been used in enough research to really say, yes, this is something that people should be using. This is still a tricky field because, of course, every site has their own preference of what they want to use. So I will end this entire presentation of how we can get to a more unified approach. Now, if you look at the domains affected by MS, as I said before, the BICAMS captures the domains that are most severely and most commonly affected, namely information processing speed and different types of memory impairment. Now, this is not to say that those 2 or 3 domains are enough. They capture most of the cognitive impairment, but really not all of it. There are also patients who do not have information processing speed deficits and might have a problem in attention, for example. But it is used as a good screening. Now, this is an overview of the Amsterdam MS cohort, and you can see we divided patients into cognitively preserved, mild cognitive impairment, which is a deficit that is not so severe, but at least on 2 different domains. And CI is more severe cognitive impairment, meaning the deficit is more severe and also in multiple domains. And if you look at this, around half of our population showed some form of cognitive impairment, which is much higher than we previously thought, also because there's a clear mismatch between subjective experience of the patient and the clinician and what comes out of neuropsychological assessment. This is important because it means there's a real clinical role for more advanced neuropsychological assessment in MS. MS cognitive impairment has a very strong impact on quality of life, and it can also lead quite quickly to unemployment. People cannot drive a car anymore. So it is important to capture this early on in the disease, but also to have a sort of normative baseline for each patient, if possible, so that over time you can monitor this and have a look if something's going on. In early stages, this can already happen. Some patients at diagnosis will already be able to be labeled as cognitively impaired, although this is not as common. And as you might expect, patients with severe progressive MS with lots of neurodegeneration, of course, have a more severe profile. But this is not to say that it is unique for progressive MS. The tricky thing is that there's strong heterogeneity in the presentation of cognitive dysfunction or impairment in MS. As I said before, many different domains can be affected, although there are some patterns and some cognitive phenotypes have now come out. But there's a clear disconnect between cognition and very conventional clinical MRI measures. Mainly T2 lesion volumes, for example, do not relate that well. Now, if we look in a little bit more detail, this is a study to highlight relations with lesion location and different cognitive tests. And as you can see, there are some relations. So if there is something orange, there is a relation with the domain. But how we could use this in clinic is very unclear, and it really does not explain a lot of the variance. So there's more going on. I guess that is the theme of the day, that very simple lesion metrics are not enough, and we know a lot more. If you look at PIRA, and PIRA I will get to in a second, but more advanced lesion measures like PRLs, this is really early days in cognition, but the general picture also holds. People with more paramagnetic rim lesions have more severe cognitive impairment and higher risk of developing cognitive impairment, but we need more studies. So there has been a lot of debate about if there is such a thing as a cognitive relapse. The problem here is a relapse, of course, is something that is transient. And because it is transient, it is difficult to capture because repetitive cognitive assessment on a short time window is problematic because of learning effects. But there has been important literature by Ralph Benedict showing clear relevance of cognitive measures during some relapses. Here is an example of a patient experiencing a cognitive relapse and then the recovery after. And as you can see, perhaps some cognitive areas are affected, but this really doesn't have to be the case. Now, if we look, this is a really nice, I would encourage you to read this paper to explain this figure in more detail. You can see that this relapse lasts for varying amounts of months, but that there is a transient deficit, for instance, in processing speed, but it can also be other domains that then goes back up again. So this is something that we have to know, but it is unclear how we can implement this in clinic because it is quite labor intensive to do a lot of this cognitive testing. So there might be a role here for remote monitoring or apps or things like that. We also published this case that I always want to highlight because it also reflects a different aspect of MS pathology. This was a young woman in her 20s who was in university who suddenly could not study for her exams anymore. It would not stick. And she did not have a diagnosis before, so she went through extensive assessment, and turns out she had MS with a first presentation of cognition. And as you can see, the hippocampus on the bottom right was severely affected already early in the disease. This is quite rare, but it can happen. So that is again why it is important that neuropsychological assessment plays a role in the clinical management of MS. And afterwards, on the bottom left, you can see also spinal cord lesions developed, and then a more conventional MS pattern can be seen. Now, these cortical lesions that we already heard about before are very important for not only cognition but also physical disability, but very difficult to visualize. If you use the most advanced imaging metrics that we have that are also feasible to do in clinic, like double inversion recovery, we can see around 20% of all the lesions that we are seeing, but there's much more if you look at the pathology. Cortical lesions are strongly related to cognition and preferentially also affect some cognitive areas like the hippocampus. For some reason, the hippocampus is very sensitive to demyelination, and there you might also see some contrast-enhancing lesions, but in general, in the rest of the cortex, this is really not the case. So it's not only difficult to visualize with DIR, but also contrast enhancement will miss new cortical lesions. Now, as I said before, there is an issue with repetitive cognitive assessments. This is a nice study by Tom Fuchs. A lot of the work that I'll be presenting today is by Tom Fuchs, who is one of the postdocs in my team, but did a lot of this work with Ralph Benedict. This is a study looking at different intervals between cognitive assessments. And you can see the first line going up. This is the learning effect if you do rather short repetitive assessment with the same cognitive assessment. Nowadays, also Tom's work has shown that there are different versions of the same test, which really limits this learning effect. And if you increase the interval, this is also already solved a lot. But this means we need clear criteria when we think a decline on a cognitive test is meaningful. And this is something I'll come back to later. There's another study that Tom also recently finished using data from Prague with very high density repetitive assessments of the SDMT. SDMT measures information processing speed and is one of the most commonly used measures of processing speed, a measure of cognition. But as I was also discussing with Iris, this is one measure and one cognitive domain. Not all patients will have a deficit in this test, but can still have cognitive impairment. But a lot of research has been done with this test. And as you can see, repetitive assessment leads to an increase in performance, but there is a plateau. So this is important to know. It is not a continuous learning effect, and you can correct also in earlier stages of this graph for this learning effect if you know what the cutoff is. For instance, 8 points decline on the SDMT is shown statistically to be clinically meaningful. So for every test, you have to know what is the learning effect and how can we correct for it. So a lot of work has been done on the different batteries, looking for meaningful cognitive change, using statistical methods to determine for every cognitive test what the threshold is. Unfortunately, usually this means this has to be repeated for every country because a lot of the cognitive assessments are language dependent. So there's a lot of work that we still have to do. And of course, a lot of work has also been done by Iris Penner here from your beautiful country. But also, if you look at the literature, Switzerland is one of the front runners in this field, so it's really great also to be here. Now, if we can measure cognitive decline reliably, correcting for these learning effects, then we can see specific patterns. So we saw this framework already. PIRA is well known and now extensively being studied, but a lot of these studies are biased because they only look at the EDSS to determine PIRA. Now, what we wanted to do is if this framework also holds for cognition. And this is the study that I'll go into in a little bit more detail. And the answer is, as Iris also said, yes, there is such a thing as cognitive PIRA. What we don't know yet in enough detail, I would say, what the differences between PIRA and PIR-MA. PIR-MA is if there's also no MRI activity. Everything points towards that actually a lot of the clinical decline is independent on the formation of new lesions, that it does impact it to some extent, but some patients really decline without MRI activity. So this means, this is also a study from Switzerland actually, that we need to harmonize these definitions across the PIRA spectrum. Not only for physical disability, in terms of which window of EDSS progression should we look at, how many months should someone not have a clinical relapse, but the same also holds for cognition. How do we quantify cognitive PIRA? What is the role of the SDMT, but also especially non-processing speed tests? That we don't know yet. So the definition that we used for our cognitive PIRA study based on the SDMT was no relapse between the two measurements and no relapse also 9 months before and 9 months after. This is quite conservative because this is the first study that we really wanted to screen out anybody who had a clinical relapse during the time window. Now, this was a reanalysis of the Buffalo MS cohort that Tom was able to acquire with Ralph Benedict, but we were able to collaborate. And you can see, just like I showed you before, around half of these patients showed cognitive decline. Not just impairment, but also decline over the time window. If you then zoom in further, of the patients, so half of the cohort had cognitive decline, and those patients who had decline, almost all of this decline was PIRA. You can see that in the top, like on the right, I will show you here. Yes, the 6% means 6% showed PIRA on PIRA and RAW on any cognitive domain, and this is based on the BICAMs. And as I said before, the SDMT is the most strongly studied, but as you can see here, the other tests of the BICAM also show PIRA. Now, beyond the BICAM's continuum, we don't know yet which tests are most useful, but looking at the difference between the individual tests or combining them, you can see you capture a lot more if you increase the number of cognitive tests. RAW only, just like physical disability, is a minority of events of cognitive PIRA. So then the question is, how does this relate to conventional measures of PIRA related to physical disability? So we further subdivided patients into if they experience EDSS progression or not. And there you can see the majority of cognitive PIRA cases were independent of EDSS worsening. So this is just to show you, you cannot group everything together. It doesn't mean that patients who progress are all the same. Some patients will progress on physical disability, others on cognition, but both can be PIRA events unrelated to each other. And some are overlapping. So what you then also see, this is another study looking at a similar concept, that if you look at changes in fatigue and cognition in the absence of physical PIRA, you see that a lot of these events come forward. So this is really early days, but I think it's a very important observation that we are missing a lot of the different types of PIRA. Not just cognition, I think we have to broaden the spectrum even further, and then the question is, how do we standardize all this? Back to mechanisms now. What does it mean and what is driving this cognitive PIRA? What we know is, as I said before, neurodegeneration is an important factor in MS progression. But we also see, if you look at this very interesting study, you see here on the left, doesn't work. On the left you can see healthy volunteers and how they progress in terms of normal brain atrophy over a period of 12 years on the same scanner. On the right you see an MS population. So the MS population, around half of them actually show a normal pattern. So they don't have a lot of significant atrophy over time. But some people, like the one at the bottom, showed 1% volume loss per year, which is really extensive. Those are the kinds of patients that we also see with a lot of cognitive issues and cognitive decline, and also cognitive PIRA. Then the next question is, can we stratify this early on and do something about it? That's where a lot of the work still has to be done. This was already mentioned, that I think brain atrophy and neurodegeneration will take a more center stage role in not just clinical management, but also risk profile stratification, as well as the more chronic aspects and more the severity of lesions. Now, we had a look at our Amsterdam MS cohort to identify what predicted cognitive decline, not necessarily cognitive PIRA, because this was before the PIRA window. But what we were able to do is show that there are specific patterns if you divide patients into early or relapsing phases and later progressive stages. It looks like there are different kinds of disorders, as was also hinted at before. What you see in early stages, that white matter integrity, so not necessarily lesion volumes, but the severity of damage, this also fits well with the PRL kind of approach, is predictive, as well as deep gray matter atrophy and especially the thalamus. Now, if you look at more progressive stages, the shifts towards the cortex. So this again fits well with Alessandro and Christina's studies on that PIRA seems to be more focused on cortical neurodegeneration rather than the deep gray matter, and that maybe the deep gray matter is more relevant in earlier stages. This, of course, is an early study, so we don't really know if cognitive PIRA also holds in the same framework, and we think especially the right side of the graph would be center stage here. So the reason why we think the thalamus is so important in early stages is because we know thalamic connections in the brain are very, very extensive. So if a new lesion forms in the brain, it will almost always hit some form of thalamic cortical tract. And then especially then in those disease stages, this will have a large impact on patient functioning. Interestingly, we don't see that many thalamic lesions or direct thalamic damage. So this is an interesting thing with these MRI markers. Is it always a direct measure of pathology or a sort of summary measure of what's going on in the brain? So going back to lesions in the white matter, this is an interesting study just to show you that this concept of there's more to meet the eye in the white matter than lesional pathology. If you look at normal appearing white matter damage, you can see that there is a specific role for cognition. So this hasn't been studied well enough for cognitive PIRA, but if you let go of white matter lesions and look at the normal appearing white matter, you see damage is extensive, can be quantified now, at least in a research setting, and this is strongly correlated also to cognitive decline. If you then look at this nice meta-analysis looking at which regions would then be most important, so not the lesions, but this diffuse damage, then you can see some patterns forming. You can see that it doesn't really fit that well with lesion location, but a lot of it centers around the thalamus again. So for some reason, thalamic microstructural integrity picked up with diffusion imaging has been altered. That seems to be independent of lesions. So perhaps this could be due to synaptic changes or more smaller changes that are not picked up with clinical MRI. And this is a study that we did looking at the different cognitive domains and their relationships with this kind of damage. And again, you see the thalamus is important in all, and some of the domains like attention has a lot of frontal predominance, which might seem obvious. But it's good that we find some of these patterns, because then maybe we can move towards clinical implementation of a general predictive bad sign for cognition focusing on the thalamus. And this concept of structural networks. This can also now be quantified in research. I think in clinic this will be very difficult to do, but studies have shown that structural disconnection, not just driven by lesions, but also microstructural damage outside of lesions, is strongly related to cognition. Now, if this damage is now then focused on non-lesional damage, more chronic cortical pathologies, what happens to brain function? Because that is, of course, the bridge between structural damage and clinical functioning. This is a map of the Netherlands with different cities in the Netherlands depicted as the dots. And then some cities are a network hub in the sense that they have a lot of connections. Other cities, like the one at the bottom, Maastricht, is not a hub because it does connect to only one. The brain also works in the same way. The thalamus is one of the green super hubs, and other brain regions are more specialized and are not hub. So if you would then look at brain function, if someone wants to move from Den Helder to Maastricht, you don't need the entire network. Brain also works in the same way. You don't always use your entire brain all at once. So this red line is the shortest path between the two cities. In the case of MS, this happens. Structural pathways are disrupted and if not always completely destroyed, but they become less efficient, they become slower. That's also what we heard this morning. And then if you look at the functional studies, we see a lot of this. This is something we can now also quantify, the sort of line that is drawn throughout the brain for information to come from one end to the network to the other. This basically means your network becomes less efficient, less complex, and slower. This might be why information processing speed is such a predominant factor in MS. So this is just to show you from one end to the other. We see progressive MS, especially those patients with a lot of cognitive difficulties, have a less efficient and less complex functional network architecture. There are also some people who have quite a lot of damage, quite a lot of lesions, but don't show this. So there is some sort of compensation that is possible. And what we see is that some of these network hubs seem to be metabolically working harder to preserve the normal network architecture despite structural damage. There's some hope in this because hopefully we can stimulate this compensatory phenomenon with things like exercise, cognitive rehabilitation, brain stimulation. Also there, it's early days. This is just to show you this concept. So if you have structural pathology, you get impaired cognition or not, depending on the cognitive reserve and compensatory proficiency of the brain. Part of it is driven by something very simple, which is the level of education. We see people with a high level of education have a lot of cognitive reserve and seem to be spared for the impact of structural pathology. So for us researchers, that might of course be good news, but there are also people who are highly educated who unfortunately develop severe cognitive impairment quite rapidly. So it doesn't solve everything. Part of it could be to the genetic makeup of the network, but this is something that we really don't understand yet, or if it is trainable. So what do we see in these fMRI studies? This is an example of the work that we did looking at the cortex. This is a resting state study, so that means the person is in the scanner, not doing anything in particular, and we look at the amount of connectivity going from one region to the next, looking at these hubs. People who are cognitively preserved, so with the normal cognition, see these abnormalities in the motor system, which is related to the severity of motor impairment. But if we look at the cognitive groups further, this happens. This network that shows up in orange is the default mode network, and as well as the frontoparietal system. very, very important cognitive super hubs in the brain that become overloaded. The more orange it is, the more connectivity flows through these regions. This is quite contrary to what you would expect, because you would think structural disconnection would pull the plug on the brain, but we actually see more happening. And this is something we don't really understand. We think it is partly driven by observations of loss of synapses, which was mentioned this morning, but specifically the loss of inhibitory synapses. So perhaps there's a loss of inhibition in the brain leading to this escalation, or that superhubs are preserved and everything, all the information is rerouted there. Also relevant for EDSS, but of course that's not the topic of today. Now I hope the movie works. Yes. This is processed fMRI scan of 2 different people with MS. On the left, you see someone who is cognitively preserved and has a behavior of these networks that is similar to healthy volunteers. On the right, you see a person with very severe cognitive impairment. Now, what you see is regions become red or blue, so dominant or non-dominant at that point in time in the functional network, and this shifts a lot. This is normal. Even if you lie in the scanner and you're supposed to be doing nothing, your visual system becomes active, your cognitive systems become active, and so on. They fluctuate. You see this anti-correlation between default mode and visual areas in the fluctuating lines. On the right, you don't see this anymore. These networks seem to be stuck during this window of measurement, and they become less flexible. They move less in terms of functional changes, and this is one of the major factors, that loss of correlation between the networks. So normally they would inhibit each other or stimulate each other, and this cross-play between the networks is seemingly lost in these individuals. Question is, can we do something about this? Hopefully we can bring these people back to the left with rehabilitation strategies. We don't know yet. Now, general observations in this field moving forward is that the network of the people on the right are less organized, more unstable, and they cannot recruit these networks to perform these stereotypical patterns anymore, which is then also quantified here. This is a very complex method, basically simulating the amount of energy required for a person to move between these different states in the functional network. And we see that people with more severe cognitive impairment require much more energy to perform this normal dynamic behavior of the functional brain. So this, I think, is an important mechanism that we really don't understand well enough, and is not enough to only focus on neurodegeneration to really understand cognitive PIRA, for instance. So that's why I think functional imaging has an important role. We also study a lot the relations between structural damage and brain function, and there's also this mismatch here, even with neurodegeneration and structural disconnection. So we don't understand a lot of this functional divergence yet. Partly because we also don't know why some people are much more proficient at compensatory phenomenon and this increased metabolism than others. Taking together all of this, we think the cognitive progression in MS and cognitive PIRA is driven by a network collapse phenomenon. In early stages, we have lesions forming, which has an impact on thalamic atrophy, which will be at some point felt by people with MS in their cognitive speed, because the green line of network efficiency is slowly going down. As this happens, patients can still reroute information. There's a lot of compensation still going on, and clinical impairment is relatively low. But as someone moves further to the right, and hopefully we can prevent a lot of this now with the newer treatment regimens, but unfortunately PIRA also seems to still happen, more progressive stages and patients with a lot more cognitive PIRA seem to have more cortical atrophy, network efficiency is lost, and hubs are overloaded. This increase in function is something we don't understand, but rerouting seems to be lost and the network is stuck. So the question is here also, can we move people to the left? Can we not only prevent, but really unstuck the network? Some open questions here. Why does this happen? How can we study this in a better way? What kind of measures should we include in order to move this towards clinical trials? And what about fatigue? Fatigue is another very important factor that I didn't mention before, but there's an important review that was published also from here. Fatigue is a concept that is very prevalent in MS that is also strongly related to these concepts, but does not perfectly overlap with cognitive impairment. So it is not the same. So I would urge you to read this review for more information. Now, how do we move forward now in clinical practice? The problem with cognitive measurement is that it's strongly heterogeneous. I painted an idealistic picture that we have these three cognitive batteries. Everybody should use them with standardized criteria, but a lot of research studies are doing a lot of different things. So we, together with ECTRIMS, as IMSCOGs, have launched this initiative to design guidelines for cognition in MS to really make sure that everybody's doing the same thing in a validated way that can be used across the world. So to develop these guidelines, we invited a lot of different experts to brainstorm with us and to vote on these criteria, focusing on 3 different aspects. Cognitive screening. So this is not an advanced neuropsychological assessment, but what can be used, STMT maybe, to perform a first sort of initial thought is maybe something going on. One important thing to note, clinical judgment without actual testing is tricky here, because a lot of things are missed. Then cognitive measurement and diagnosis. So if you want to really diagnose cognitive impairment, what should we do? And then cognitive change. So after a diagnosis has been made or not, what if you repeat the assessments? What should you look for? What cutoff values? How much should someone decline in order to not have these learning effects or noise effects there? So some example questions that we designed and voted on. If you do follow-up assessments, should everybody use alternative forms, alternative versions of cognitive tests? Is this enough to overcome everything? What designs should we do to have clinically meaningful change? So how many points practically on what tests in what country should be present? And how should we handle MRI? Is there a role of MRI? Is that enough already to be used in clinic? So these are the different countries around the world that we were lucky enough to get experts in. And we completed the first version of the manuscript, which will be submitted very soon. So look for the cognitive guidelines in the hopefully next 6 months. Thank you very much for your attention.